Thank you. May we call upon the following speaker, Dr. Hassan Thani. I think he's in the floor. Yes, please join us. Prevalence, management, and outcome of pulmonary embolism in National Referral Hospital in Qatar. Eager to listen to that.
Assalamu alaikum. Thank you again for the opportunity to present. I'm going to touch on the prevalence management outcome of pulmonary embolism in Qatar. I have nothing to disclose regarding this presentation. Acute pulmonary embolism causes widespread morbidity and mortality, and computer tomography is the image modality of choice for suspected PE, demonstrating high diagnostic accuracy, has a clinical radiological implication for risk stratification in patients with PE. Our aim is to evaluate the prevalence, the management, outcome of patients with pulmonary embolism at National Referral Center. We include all the patients who were referred for CT to rule out pulmonary embolism. We had 3,200 patients. Out of these, 258 patients were included. Majority were actually young, 50 years, plus or minus 16. 57% were male. Qatari account for one-third of the patient. And the majority were obese with a BMI of around 32. We had the duration of follow-up was 52 days, but it ranged between 1 to 5,488 days. The hospital length of stay was 8 days. So the presentation of these patients, the majority presented with chest pain, dyspnea, less likely with cardiogenic shock, and the location of the diagnosis were ICU or in the emergency departments for 2/3 of the patient, and 26% were through the in-ward hospital. The risk factors were actually history of deviant thrombosis, accounting for 23%, history of surgery, more than 24 hours, and 23%, and the rest were actually small. Cardiovascular risk factors, hypertension was common, nearly 40% of the patient, coronary artery disease, and 16% of the patient, myocardial infarction, and 5% of the patient. Coagulation profile was also, with abnormality, was very high. So we have high percentage of protein C, S deficiency in nearly 30% of the patient, hyperhomocystinuria in 21% of patients, and the rest were small. Of interest, actually, lab investigation, 92% of the patients who had PE were D-dimer positive, and we have 7% D-dimer negative. And troponin was tested in nearly 66% of the patient. These are actually the findings on the CT scan we looked at. We looked at right ventricular, left ventricular ratio, bowing of the intraventricular septa, pulmonary artery diameters, aortic diameter and ratio, as well as the superior vena cava diameters, and the burden of the clot were assessed on these patients. The management also, as outlined, we had patients who had anticoagulation and patients who had thrombolysis only in 7.2% of the patient. The complication, leg edema, was present in 20% of the patient, pain in 15.4% of the patient, and mortality was high, 9.3% of mortality. But the cause of mortality not all related to PE, only 2.3% related to PE. We compare the burden actually of the disease on survival and non-survival. And in the survival group, they were younger and with less comorbidity, especially diabetes mellitus, coronary artery disease, and hypertension. We also looked at the finding of the CT scan in terms of the parameters. The only thing of difference between survival and non-survival were the superior vena cava diameter was much less in comparison to non-survival or survival, and statistically significant. The burden of the disease, the Kundalini score, we compared between the twos, and the of significant between the high burden with low burden is the D dimer, the troponin level, and the abnormal coagulation profile. And also we looked at the parameter which indicative of right ventricular dysfunction, and actually all of significant when we compare the Kundalini score less than 18 versus more than 18. In terms of treatment and outcome, of significant only thrombolysis, and there was a trending to mortality benefit for less Kundalini score. When we look at independent predictor for right ventricular dysfunction, of significant were actually bowing of the intraventricular septal defect, reflex within the inferior vena cava, and the burden of clots. Also, ROC curve score is of significant, and the Kaplan-Meier score of significant for these patients. So to conclude regarding this study, despite the new modality of diagnosis of PE, mortality is still high. CT scan has a clinical radiological implication for risk stratification in PE patient, increase or elevated troponin level associated with high mortality in PE patient, and clot burden is associated with higher right ventricular dysfunction in these patients. So, future direction, the way to move forward in improving outcome of pulmonary embolism is scalability of data to identify care gap through better screening and compliance with guideline for prevention. So what we did is actually in terms of scalability of data, we looked at different parameters and we addressed them, scored them, and actually published them to see where we can find a gap in our knowledge, how we can address it, how we can improve in it within our center, and how we can improve our outcome. In terms of actually screening, we have a screening profile being implemented within HMC hospitals. We look at how we can improve on all the screening parameters, but if you have a screening parameters, you have to have a compliance with guideline for prevention within your hospital. So we look at all the floors in our hospital, and we look at root cause analysis for why we don't compliance with our protocols, and we try to solve them. Prevention protocols, very important also. And if you have a prevention protocol, look at the detail of your prevention protocol. Is everything working right? And if it's working right, how you can improve on the outcome of our patient. One example of this is a trauma patient with PE rate was very high, and we implemented anti-factor 10 guideline thromboprophylaxis based on weight and evidence, and we found that we can drop the PE incident from 4% to 1.3%. So there is a chance that you can improve. Also, if you have a guideline, you establish actually a multidisciplinary pulmonary embolism response team. And with that, we establish actually activation protocol, we establish a diagnosis algorithm for this patient, and we establish a treatment algorithm for the patient. We have a medical therapy for these, catheter-directed therapy, and surgical intervention for these patients. With all this implementation, you can make a difference. Thank you for the kind of invitation.